Yes. Hi, okay, we're starting. So I'll be presenting the last case of the night. So this is a 66-year-old woman, comorbidities, hypertension, history of possible right hemithyroidectomy 30 years ago for a benign condition. She presented to us with a 1-year history of progressive dysphagia to solids, with intermittent cough with minimal hemoptysis for the past 2 to 3 months. No vomiting, she didn't complain of neck swelling, she had no change in voice, no fever, and no other constitutional symptoms. On examination, there was a hard left neck swelling, 4 by 8 centimeter, and you're unable to get below it. There's no palpable lymphadenopathy. So, investigations.
In this section, I would like to also invite all the trainers in this room to participate, to ask questions, just in case I miss some of the important, pertinent management or flow of the story. So you can also ask questions, can ask for the mic. I think the chair will distribute the mic to anyone of you who wants to actually also ask questions at the same time. Okay, so for the first one, we open it up to the trainees to volunteer to answer. Because this one, if you answer the earlier questions, then it will be easier. Answer the more difficult ones, was it? And yes.
At this stage, my impression would be that in her pregnancy. So I will proceed with the ultrasound thyroid and then gently, or at least with the chest X-ray because she has a intermittent cough with minimal hypothesis of speaking that there is metastasis.
So for the ultrasound, specifically, what would you like to look out for?
I would like to look for characteristic of environments, with considerations.
Okay. Any other investigation? That's
TFT, therapeutic test. And
so if it's malignancy, what do you? I mean, it's not really. It's association. It's just an association. It's not really the usual picture. I mean, the common picture that you get, but it's just an association. What would the thyroid function test show? If it's malignancy,
hypothyroidism.
Hyper. Why hyperthyroidism? Why do you ada tiga kan hypo, normal kan? Okay, which one would you choose? Usually it's not mesti, but it's just an association. Kalau ingat tamu nak.
I was thinking hyper.
You will say hyper. Reason?
Well, from my
Experience.
observations, patients with PTC also can present with
Yeah, they can present with anything, but usually hyper is a bit lagi rare daripada hypo or normal. Hypo is normal. Tapi it's just an association, not necessarily.
So if the thyroid, thyroid shows as suspicious, then I will proceed with that thyroid, guided pregnancy.
Okay, all right. So those are the initial investigations that you have. And you ask for chest X-ray. That's the chest X-ray. And when anyone wants to comment, you just It's actually good. Uh-huh. Hmm. Where? Which one? Which part? Which swelling? Soft tissue swelling.
Soft tissue shadow.
So you mentioned the classification over the neck region with the thyroid.
And the left, what's it called, the left aromatube calcified.
Okay.
The trachea look pattern, but there's, I think, looks like the trachea looks okay, the size and trachea is pattern.
Okay. The soft tissue is up. What is it that you mentioned?
There's a soft tissue shadow, but it's same actually.
Where?
Soft tissue shadow is could be the neck, maybe the
Is that normal?
yeah,
Normal or
could be
abnormal?
normal. It could be normal.
Looks normal, yeah.
Yeah.
Okay.
Otherwise, there's no the lungs looks. Yeah.
In the lung field, what are you looking for? Or what are you looking for?
From here is a PE view. I think we look for any planted concentrated angle to suggest a nuclear effusion,
Why fluid infusion?
to suggest maybe lung metastasis. But usually,
Does not direct.
yeah, usually they go for nodule rather than lung effusion. Otherwise, the lung, the chest X-ray, the lung looks okay and a bit hyperinflated.
Why is it hyperinflated? What's the definition of hyperinflation in the lung?
Because it's this not sure, but from
There's
the
a definition.
eyeball, yeah.
Hyperinflation has got its own definition.
Yeah.
So you count the intercostal distance.
Yeah.
So if it's not, yeah, it's abnormal,
Yeah.
it's not hyperinflation.
Yeah.
It's normal.
It's okay. Yeah.
So you look for certain days, but make sure that you don't go overboard, finding something that is not there. So,
But otherwise, I think that's classification of the left nodule only.
stop where you need to stop.
Okay.
Learn that. Whenever you need to stop, you stop. That's it. Okay. Someone asked for an action plan. Anyone wants to comment on this? Okay. So.
Sorry, based on the ultrasound, start from the top one,
I have a pointer, and I think it gives you a pointer. Fine. Sorry.
how this is of you over the left side. And
Sorry,
right.
it's tiny.
So,
You're right. I'm not.
No.
Oh,
Or is it in my iPhone? Oh. My God.
Just keep
Get
pressing
a height decision X, right? He is not over the height. And it's well defined. He's hypoechoic. And there's macro oscillations.
Just go press next.
Where do you see that calcification?
This there's it's a hyperechoic. And there's a posterior shadowing
Okay,
also
good.
behind.
Yeah.
These two image, because the hypoechoic and macro oscillations, transmission actually correlated.
Okay. The next one.
Left side. Left side, there is not a nodule with constriction. It's very hypoechoic, this one. Not under the access because there's a rim of constriction.
Okay. So there's a ring of calcification around that.
around
part.
the source, the only part is the calculation, it's not entirely. Let's say you can see the entire calculation is more than benign, part of calculation is quite sufficient. And you cannot assess whether it's any extra or other additional because the posterior shadowing of the calculation.
Okay. So that one same one, law, left thyroid, this one, yes, the one that you want to.
It's fine. The concern in this case is because I think look from here it's more than taller than white.
Okay, that one is smaller, right?
More than white and it's irregular operators and micro frustrations.
So in conclusion, that one bawah, it's a difference. Can you comment on the difference?
But it's
That the bawah is the that's my question.
for this one on the this table is longer shapes and there is no loss of adhesion thyroid. It's very suspicious, you know.
So overall,
Overall, I would say this is because in the presence of lymph nodes and also on the suspicious with nodules constellation thinking more toward academic thyroid sensor.
so what's next?
Next, I would based on this, I arrange for ultrasound guided FNC to I think at least 2 of the suspicious nodules.
What about the difference?
I think I don't proceed at this point.
Why?
Because it's from the imaging is always suspicious. If we can get the diagnosis on the A of the nodules. So if it's correlate, which public thyroid CX only match the numbers, so doesn't require the diagnosis of the numbers.
So you're gonna proceed straight with
Then liver dissection.
liver dissection
Yes,
without FNA.
without FNA.
Right, next.
So before I show the results of the ultrasound guided thyroid, any other investigations you'd want to do for her based on her symptoms, based on her history?
Also, spatial patient for GDS as well.
Yeah, because the chest X-ray is normal and then we have dysphagia and hemoptysis, so we proceeded with an OGDS as well. So there was a tumor below the cricopharyngeus with contact bleeding. So we biopsied this as well as the ultrasound guided biopsy of the thyroid gland. These are the findings.
Can read
Sorry.
the
Right, so from the OGDS, you have neoplastic cells which display enlarged overlapped nuclei, inconspicuous nucleoli, and some showing nuclear grooving and nuclear clearing. So from the FNA of the left thyroid, basically you have the same, you have crowded overlapping nuclei with nuclear enlargement and grooving. Chromatin appears powdery, intranuclear pseudo-inclusions are seen.
Okay, anyone wants to comment on this?
In the both OGS and ultrasound guided techniques of the thyroid module, subjective of CA because of the nuclear features. So of overlapping, nuclear grooving as well as nuclear clearings. So that open end high. So this is subjective of. So I will, the next step for me, I will suggest waiting for CT scan because of movement of the.
If you are the pathologist managing this case, is there any other things, any other staining that you would want to do? I mean, usually surgeons ni dia pada kaki panjang sikit. Tapi pathologists usually they think depan sikit. Or they do some extra things that we say that, oh, I don't need this, tapi dia orang buatkan juga untuk you.
The F1 or the OGS maybe.
Which one for the
OGS.
OGD biopsy, okay? Apart
For
from TTF1, is there any other that you think that would be useful? I'm sure you have seen it in your pathology report, your pathologist report.
thyroid as well.
Thyroid, okay?
So positive for TTF1 and thyroglobulin. So final impression, metastatic papillary thyroid cancer from the OGDS and papillary thyroid cancer from the ultrasound-guided FNAC. So he wanted a CT scan.
I mean, it's getting more and more difficult. So if I miss anything, you wanna ask questions, the subscriber trainers can just inform. Okay, video, I mean the CT trainings. We will just play once dulu, and then I hope that any one of you can volunteer for that. So what's the aim of this CT scan? The trainings, what do you want to look out for? Anyone? Especially the patients got symptoms.
So we also like to see muscular frequency,
That's moving.
intrajugular and infiltrates.
Profit
And
moving.
we will also assess the lymph node composition.
Okay, all right, so since you're holding the mic, so can you comment?
There's actually a large tumor which looks like it arises from the left thyroid, extending downwards to the retrosternum, to the posterior mediastinum. I think it's all the way down to almost at the root.
It is look out for resectability. You want to look for resectability, right? In this case, because it's PTC.
The vessels look to be very ancient. It's actually looks like part of it's enveloping the esophagus. It's poking around the esophagus. So I think
Apart from the involvement of the esophagus, any other comment on the huge mass at the posterior region? Comment, not comment, whether this is perceptible or not.
think I will go for anything.
Okay, you're in the MVP. And you have the oncologist asking you apa tu NS datang, you put NS datang kan. So they're asking you, is this resectable? Do you think this is resectable?
You see the area, right? You can see where the area is.
Dia punya finding dia nampak dia cuma inside tapi tak nampak effect.
Everyone's a big is because so from the NS part of it, there's no problems with.
You can see the rice tube, right?
Yes,
Okay.
yes.
What else do you see around the rice tube? That's not supposed to be there. Okay, yes. Follow the ratio. Okay. So what you can make out of that?
So there is free air surrounding the spaces. So likely that there's some infiltration with some form of operation.
Okay, alright. Recyclable, recyclable. Alright.
Let's get our here.
Okay, so you call your RPGI is in. RPGI is asking you, what's the prognosis? What do you want us to do?
I would say at least, I don't think we will be able to achieve final resection in this kind of things, but at least we need to involve it.
Which one?
The
The whole,
the main tumor at least, the one, the part where the thyroid is, and then, well, evolve what we can.
okay. Okay, so that's the CT scan. We will move to the tension.
So we also did a contrast swallow and there was leakage from the esophagus, and the ENT assessment airway wise was okay. It's just that there was a left vocal cord palsy. So what are your concerns? Airway is patent. Yes. Could pass through the scope. So in terms of we did consult upper GI in terms of feeding her because there's a leak from the esophagus. It wasn't amenable for stenting due to its high location. So they inserted a PEG tube. So the resectability wise, the important things to note is there was esophageal invasion, and there's no clear plane with the prevertebral fascia when we discussed with the radiology. So moving on to treatment options.
Okay, we have a list of treatment options. Choose from there which one do you want. So probably we can get you can choose the ladies can choose from there which one you want to delay. And probably because of time constraint, I'll probably get and then we take one or two comments from those that choose the specific particular management. The first one, radical surgery, total thyroidectomy, esophageectomy. Berapa tadi? 60 plus. Debulking surgery and RT. Debulking surgery plus RAI with or without TKI. Okay, debulking surgery, RAI with or without TKI. TKI alone, neoadjuvant followed by surgery. Is mass lagi. Jadi mana tak ada? Adi. Okay, radiotherapy, IMRT alone followed by surgery. And angioembolization. So can I get a comment from Hadi, which is then TKI alone? Saya nak tukar.
What is the NSC code?
Intubation tak ada masalah. Intubation tu lagi mungkin ke?
Her airway was never an issue. Airway is good.
So nak tukar. Terserah kamu.
think, as far as patient concern is age 60, could be patient.
Intubation TKI alone kan tadi? So why?
I think the involvement of the length of the packet anyone. I think
Tak, paket tadi. Esophagus dia tadi, tapi esophagus GI dia tu tak boleh stand. Baiklah, saya rasa kita boleh
It's most likely, to research. I think the risk is too high because
Risk is too high, okay? A lot of mobilities, okay? So functional status more, okay? Alright, so you would rather, so nak bagi berapa lama? PKI berapa lama dulu? Tak boleh lah bagi je PKI and then dah, that's it.
looking for anyone who receive the accessibility standard.
Okay, alright, 3 minutes, so 2 sense. Okay. Alright, tadi siapa pilih debunking surgery with RAI with or without PKI? Kai. Reasons.
Okay, so basically PPC is a very treatable disease. It has a very indolent cost. So
So
I
stage berapa ni?
stage 4. Wait. Six. Because in this case, metastasis doesn't mean that there is stage 4.
Metastasis doesn't mean in stage 4 in what age?
45 below.
Doesn't have that one.
45, 55 now.
Okay, sorry. Okay. So,
So in stage?
3.
T berapa? The CT scan kata ada facial involvement. Itu COVID. Itu bagus for A. You can expect. And one, and not. Stage. Okay. So still have a good, ya kan, prognosis for PTC. You think?
Okay. So
Okay.
my
So how much do you want to give out?
as much as
For example,
as much as possible without talking up.
the consider. Consider. So how consider part, you know. The main part is that the consider. You go in like how many days?
Still consider to develop.
Okay, you still go.
But of course, the surgery is not to achieve R0. We probably do end up with R2 resection.
Okay, but it's gonna be a lot of bleeding for that one. So we have decided.
Yeah,
uh,
and if you can develop, why do you just want to develop? Why do you just want to develop?
We want to reduce the
No, my question is, why do you just want to develop if you can do it? Answer that question.
my aim to do the surgery is not to cause any further harm. Like if we are going to cause recurrent regional injury, we're going to cause.
Now they are gone. That's right.
That's it.
Yeah, that,
All the more easy is to
so I have to ask you, nobody wants to even consider, I mean, it looks like nobody wants to even think of radical surgery here.
But then again, the more we remove the tumor, the more sensitive the patient will be for RAI. The more amenable to treat the disease. If she does have any other micrometastasis, let's say any lung metastasis and all that is amenable to RAI. And by removing the top of the tumor, we can still hope for RAI. And how many of our patients can afford TKI? Can we give TKI to everyone? So if you can't give it,
So are you answering my question and turning it to my side?
I'm presenting my point. My point is, if I want this patient to have better quality of life, to have prolongs, disease-free survival, I feel that by debulking what I can and removing the tumor burden, and that's a direct relation to RAI, that is an increased chance of a survival, rather than if we just,
Right. So that's why I'm now posing it to all of you trainees. If that actually can have a possibility of actually allowing you to give RAI and all that, why none of you actually want to go one step further and think about doing radical surgery and think about how you're actually going to solve all the problems related to esophageectomy and all these things, and rather than debug and knowing that you actually leave a lot, you're not talking about, a little bit, a lot of tumor left behind to leave for the RAI to sort out. You leave as little as possible. Don't even think about not. It's not going to happen. Right? You need to think whether or not this one or two steps can be done. If people are really good, how about that?
No, standing.
They cannot stand.
They cannot stand.
I will give a lecture tomorrow on the one question. But before that, I want you to sleep with one question in mind. Tomorrow I'm going to ask you. What are the principles? My question always, what are the principles of doing this surgery? There are principles of Arnold and principles of what do you want to achieve doing surgery? Right? That I'm going to ask you tomorrow. Don't have to answer me now. Okay?
Apa ni buku tak ada.
Tak ada.
Tidur orang.
Okay.
Okay, anyway, so just wrapping up, but I can't. Can you move my slide? We had an MDT for the patient, and we decided it wasn't resectable at this point because of the esophageal and prevertebral fascia invasion. We decided to start her on lenvatinib with possibility of surgery if good response in the future. I just want to show a picture that we reassessed her with 3 monthly CT scans. After more than a year, actually, she had a very good response. Unfortunately, but it's not on this slide, the esophageal invasion remained. We did discuss with her and the upper GI possibility of a radical surgery at this point, but the patient is not keen, so she's still on TKI for now.
So that's what we did. And you can see that it's so much. You can do it now, so it's Alright, thank you.